Okay, so second to the last part, I know I said last time that was the last part, but I'm going to divide this into two parts instead of making it one long part. So how can we assess ventilation? So several respiratory volumes can be used to assess respiratory status or how well you're breathing. Respiratory volumes can be combined to calculate basically what's known as respiratory capacity, which gives information on a person's respiratory status, right? Volumes and capacities are usually abnormal in people with pulmonary disorders. And spirometers can be used. The original ones were very cumbersome, but now they have just air. Sometimes you'll see big, giant liquid spirometers or water spirometers. But for the most part now, they're just air spirometers, and they can electronically measure in an office really easy nowadays to look at and assess your ventilation. And so your tidal volume is something really easy, and the tidal volume is just the amount of air moving in and out with each breath. So for most people, this is somewhere around 500 milliliters, right? Inspiratory reserve volume, IRV, is the amount of air that can be inspired forcibly beyond the tidal volume of air taken in after tidal volume. So if you're just breathing and you're just breathing in and out, like, you know, when you go and you're about to go underneath water and it's not a normal breath, but you like really go in and you're like, before you're about to go under, right? That amount of air that you're taking in over what you normally breathe, that's what's considered inspiratory reserve. And this is anywhere from 2,100 to 3,200 milliliters. Put this. Expiratory reserve volume, what do you think that is? This, and let's just put a little mark by both of these as in forced. Both of these are forced, right? So this is the amount of air that can be forcibly expelled by the lungs. So this is 1,000 to 1,200 mils. And residual volume is the amount of air that's always remains in the lungs. Right? And so we need this just to keep the alveoli open. So the inspiratory capacitance, if you look, you can look at respiratory volumes by essentially calculating stuff. So this is a tidal volume plus the inspiratory reserve volume, right? So the amount of air that you move in and out with each breath plus the amount of air taken in after your tidal volume, right? So that's a total of air that you can forcibly overall both naturally and force bring in. The functional residual capacity is the RV plus the ERV. So this is the amount of air that you can forcibly take in after tidal volume and the amount of air that you can forcibly expel, right? Vital capacity is TV plus IRV plus ERV. So vital capacity, right? What's vital? The amount that you could breathe in a normal breath, the amount that you take in and take out forcibly. And total lung capacity is all of it. So that's the TV, the IRV, the ERV, and the residual volume. So when you're looking at total lung capacity, we're looking at the whole amount. What can we take in and out for a normal breath? What can we essentially take in above our normal breath? What can we force out beyond our normal breath? And what's left, right, in there? Let's add all of this together and figure out what our total lung capacity is, right? And you should know what those means, and you should be able to calculate all of those. And so if we start looking at these, right, you can go and look at them. So total tidal volume right here. Oops. Right, 500 mils. That's the amount that you can take in and out for a normal breath. And so if you're looking at the inspiratory reserve volume, this is the amount that you can take in over your normal breath, right? And so it would make sense that the inspiratory capacity is the tidal volume plus the amount that you can breathe over that, right? So this is the maximum amount that you can breathe overall. This guy right there, right? And then the essentially when you're looking at this, you have this expiratory reserve, which is the amount that you can, the extra amount that you can breathe out, right? Which is about 1,200. The amount here, the residual volume, is what's left just to keep your lungs somewhat inflated, right? So the functional capacity here is essentially how much you can extra that's left in or that you can breathe out, right? Beyond your regular breath. Vital capacity would be including everything but what's residual in there, right? This is vital for you to breathe in and out. What's left in here, this small residual volume, is not part of what's vital in breathing. That's what I think of when I think vital capacity. And the total lung capacity is calculating it all together. And this kind of shows you a normal recording for a male. So what do you think overall has higher readings on all of these? Do you think male or female? Males would, right? When we're talking about tidal volume, these are the same for both. But when we're talking about IRV, right, we're looking on average, women have about 1,900 compared to males that are 31. When we're looking at this down here, 1,200, right, for women, it's normally somewhere around 700. For men, residual volume is about 12. For women, it's about 11. When we start talking about adding things up, right, the total lung capacity for men is about 6,000 mLs or 6 liters, right? And for women, it's 4,200 ml or 4.2 liters. That should make sense to you guys because the average man is much larger, has more muscle, so will require more oxygen to the system, so he would be bigger. So when we look at atomical dead space, what we're looking at here are dead space in general, but atomical dead space is the area that does not contribute to gas exchange. And so this is what we just talked about. It's the amount of air that remains in the passageway. Or it consists of the amount of air that remains in the passageway. And so this is about 150 mils out of the 500 that are in the tidal volume. About 150 mils of that 500 that you have in just a typical breath is basically caught in the atomical dead space, which is all that area that does not contribute to gas exchange and the air that's just kind of present in those. Now, you do have alveolar dead space, which is just the space that's occupied by non-functional alveoli. So this alveolar dead space can happen because you just have part of that area that's collapsed, or it could be obstructed. And if it's only a small amount of them, it's not going to cause a problem. And this total dead space is the sum of the atomical dead space plus the alveolar dead space. So there is a small part that essentially isn't there when we're talking about breathing in and out, right? That doesn't essentially contribute to gas exchange. So a spirometer can essentially help us to distinguish between obstructions and restrictive disease. So obstruction pulmonary disease, essentially obstructive is going to increase airway resistance. So example of this, would be bronchitis. So you may actually get an increase of things like the total lung capacitance or the functional residual capacity or even residual volumes due to hyperinflation of the lungs. Now, restrictive disease is the reduction of the total lung capacity. And this is due to disease or exposure to environmental agents, right? So in disease, you're looking at things like tuberculosis, right? When we're looking at environmental agents, we're thinking of things like fibrosis. So on here, the things like vital capacitance, the total lung capacitance, functional residual capacity, and the residual volume actually declines. And that's because the lung expansion is compromised. You can measure the rate of gas movement by basically, well, looking at forced vital capacitance. So the amount of gas that's forcibly expelled after taking a deep breath. And if you remember forced expiratory volume, amount of gas expelled during specific type intervals for this forced vital capacitance. So you can measure the rate of gas movement, right? And they have what's known as minute ventilation, which is the total amount of gas that flows into and out of the respiratory tract in 1 minute, right? And so healthy individuals actually can expel 80% of their IVC in about 1 second. Those with those obstructive diseases can expel less than 80% in 1 second. Those with restrictive can excel 80% or more, even with reduced FVC. So that's how they can tell and be able to figure out what's happening here, right? Now, for the minute ventilations, if you're actually looking, this is what we're talking about expelling. For the minute ventilations themselves, normal, you can look at these and they change with things like exercise. And so for a normal person at rest, you're looking at 6 liters per minute. And during normal with exercise, you're looking at anywhere from like 200 liters per minute. Now, these are just estimates, right? But it can give you an idea of essentially how much you are being able to track within rest versus exercise. So alveolar ventilation, or AVR, is just the flow of gas into and out of alveoli during a particular time. It takes into account amount of dead space, the tidal volume, and the rate of breathing. So you can basically calculate this by looking at your breaths per minute in frequency times your total volume divided by breaths. And this is actually a better indicator of effective ventilation. And this is because things like dead space, right? In an individual, it's pretty constant. You can look at AVR, and it's affected by things like tidal volume and the frequency of breathing. So this can be drastically increased by increasing tidal volume rather than frequency, right? So you might be able to take in bigger breaths and less frequency. And so here gives you a better idea of the amount of gas that you're bringing in versus the previous, when you were just looking at the amount of gas that flows into and out of respiratory tract in 1 minute. This is actually looking at giving an idea of the flow in and out, taking into effect your tidal volumes and your frequency both, right? So rapid shallow breathing, you might be able to push a lot of that through, but in this case, it would actually decrease your AVR. So this is a better way of looking at things. And so this kind of gives you an idea of effective breathing rates and depth of alveolars for 3 hypothetical patients. And what I want you to do here is basically look at the tidal volumes on here, right? And so here's a normal rate, a normal depth where you have 500. But here where you have slow, deep breathing, your tidal volume changes drastically. Here's rapid, shallow breathing. So you can see how essentially, even though you are breathing essentially less, like here, it's showing your respiratory rates earlier, right? The respiratory values are artificially adjusted to equivalent minute ventilation as a baseline. But you can see here, same dead space, respiratory rates are different. And if you look looking at the minute ventilation, you'll notice they're all about the same. But how effective ventilation is different, because in here, you're showing that this is more effective because you can breathe, you have more tidal volume per breath. Versus here, you might be breathing more, faster, but you're not breathing as deeply. So those are going to drastically change these outcomes. Really quick. Gas exchange, when we're talking about this breathing, it's important because we're talking about how much gas we can exchange between the lung and the blood, because that's our ultimate purpose here, right? And so when we're talking about external respiration, we're talking about the diffusion of gas between the blood and the lungs. Where internal respiration is the diffusion of gas between the blood and the tissue, right? So this is bringing it in through the lungs, and this is giving gas to tissue. They're both basically processed or subjected to basic properties of gas and the composition of the gases that can come into the alveoli. So basically, Dalton's law of partial pressure just says that the total pressure exerted by the mixture of gas is equal to the sum pressure exerted by each gas. So each gas has its own pressure, and it's directly proportional to how much is there, right? So when you're looking at here, total atmospheric pressure equals about 760 millimeters of mercury. So oxygen makes up 20.9% of gas. So when you're looking at this Dalton partial pressure, what you do is just saying how much pressure is oxygen exhibiting on the system? Well, since it includes 20% and the total pressure is this, we get 159 millimeters of mercury. Now, what I want you to do really quick is calculate that for nitrogen. And whenever we get done with that, you get done calculating that, we essentially are going to finish or start with the last part of this lesson.